And what a beautiful gathering of nurses, scholars. Firstly, I want to appreciate the Dean of the Faculty of Nursing Science, UNIMED, the University of Medical Science, in person of Dr. Mrs. Edwards. You are blessed, ma'am. And I also want to congratulate her for putting up such a conference like this and this topic in time like this. Also, Mama, she will soon be out of where she has gone to. The pioneer Dean of UNIMED, a mother, a selfless mommy, and someone that she didn't see some of us then when we started the teaching hospital and nursing sciences program. She didn't see us as younger generations. She's always with us and very, just accommodating. And that is why we are having what we are having today. She has started well, and thank God for the person that took over from her. Currently, now that she's there, but thank God. More grace, ma. Mommy, that's Professor Oluwatosin. Mommy, you are blessed. We are proud to have you. Then we'll be going up and down, looking for how to make nursing better, how to start. What can we do? She will always come, and I will go to her. So I'm proud that you are here today again. Mama, more grace. We pray long life in Jesus' name. I want to appreciate also our director from Ministry of Health, the #1 director in the state. That's in person of Mrs. Aliu. Ma, you are welcome. Also, all the staff, our lecturers in the university, in our department, nursing department, you are all welcome. And also, the honorable in the house. Please, let's celebrate her. That's Honorable Adamolekun. You are welcome, ma. We are always together. We have to celebrate what we have. And she's doing greatly good job. You are welcome, ma. And the LOC, Local Organizing Committee, I want to appreciate us. Because if you have not called on us, and you say it's just academics affair, or you just say it's university affair, the hospital will not be involved. Thank you for the cordial relationship that we have, and thank you for all the committee members. I celebrate you. Any day, I celebrate you. We are talking about the theme this year, talking about innovations in patient care. And believe me sincerely, the keynote speaker have said a lot. When we want to have improved care for our patients, there are many things we can do that we can bring to our hospital or wherever we are caring. And as we all know, like the last speaker have said, nursing is caring. Either you are in the university, either you are at home, home nurse, or wherever you find yourself, or in the clinics or clinicians. What are we doing? We are caring. And that is why she has talked about a lot of things that we can bring on board so that we can provide better care for our patients. And also, we are talking about exploring new technologies and also strategies for this improved care. And that is, if you are talking about innovations, or at the same time, what other strategies can we use again is our care, the quality of care we give to our patients. And before we go to the introduction, I want to go by the definitions. What are the things we see in that topic? We are talking about, the topic that we'll be talking about is quality nursing care. The idea and also the reality that we have on our hands. So there are some things that are peculiar in that definition. We have quality. And all of us, we know, when we talk about quality, we are talking about the standard of something or measures against other similar things. That is talking about standard of something that this one is quality, how you rate it. And when you bring it down, you look at the services we give to our patients in nursing. We can say in health care, quality will mean that how well service we give to our patients, how well, how good that the what they are the desired, the quality, the desire that we want, the kind of care we give. And another thing we see in that topic is nursing. Nursing that we know for many years. And that Virginia Anderson, a renowned theorist, in 1960, she gave the definition that we still remember vividly till today. And according to her, we can see, it's talking about the function of the nurse. What does he do? Helping the patient to do those things he will have done if he has the will or he has the ability to do it. And not only that, we want to make her independent so that he can do those things, or even to a peaceful death. The care we give goes a long way. And for many years, we know that has been one of the most influential in nursing theory and practices until this month, that nursing was redefined. The new definition of nursing came on board. We see from the conference that just ended, that took place in Helsinki, that's in Finland, between June 9 and 13, because they look at it and they said, what can we also add to make nursing meaningful? And also some of the texts that we see have the terms. We look at care, and generally we say care is the provision of what is necessary for the health, for welfare, for maintenance and protection of someone. And in nursing, this involves empathy, compassion, and medical support. God will help us, because these are the things that kept us as senior nurses and caring. All those ones have to be there. When you are caring as a nurse, it will involve empathy, putting yourself in the position of the patient. It will involve compassion and medical support. But let me put it to us. We still have it. What are the things that will drive you when you are caring in nursing? Then, and I still believe, was passion for the job, passion for the profession. When the passion is there, it takes you to any length to help in caring for the patient. And we also see ID. When you talk about ID, these are standard. What people believe this is right. ID based on certain standard. You say this one is ID. And reality is what? ID is what is expected. But reality is what? What we have on ground. What we see around us. That's reality. And then what are the importance? When you talk about quality nursing care, before we even go into it, what will it do? What will it give us in health care? And that is the outcome. When you give quality health care that we are still going to, you will see patient outcome improve. It will improve the outcome. Instead of staying in the hospital for long, instead of the patient going and coming back, you will see improvement in patient's condition. Then there will be enhancement of patient satisfaction. Say, that nurse, in that hospital, the nurses there, no, they did their best. Then it will reduce mortality and morbidity, because you are giving the quality care. You know what to do. And also, the trust that the patient has in us, we also do what? We increase. Unlike when they say, nurses are, I don't know. But thank God for what we have now. This generation, what do we see? Nursing is better. Like the keynote speaker told us, that she's proud to be a nurse. So, because of the level we are now as nurses and the profession, then there will be better health promotion. One of our duties as nurses is to do what? Promote health and prevent diseases. So all this one will also be achieved. And when we talk about standard, we said ID is what we consider standard. Is what we see based on the standard. And you will read that one. You will see there are standard and framework by our body, and that governs caring. We have the one from WHO that talks about patient safety that he has laid down. So it means you want to weigh this quality based on the standard. Patient safety and quality care. Also, WHO talks about as nursing. What again do we see? He also said the nursing workforce development. It is when you develop the workforce that they can give. You can't give what you don't have. Also, it's just like we are reminding ourselves. We know all these ones in the past. Also, leadership and the registration that governs. Like we have the Nursing and Midwifery Council of Nigeria, the governing that quantify our certificates and does the regulation. So all this one, when you look at what you are getting from it, what the leaders are doing, what our bodies are doing concerning the profession, then you can weigh whether it is standard or the standard care or not. Also, another framework is also the universal health coverage, the UHC, universal coverage, health coverage. You can see what we have there, that we can also base the quality upon, and ethical and that other ones. Still continue. We see the four core elements of International Council of Nursing of Ethics. International Council of Nursing Code of Ethics. You will see all those ones. How do you relate with your patient? The nurses and the people, the patients, and all other ones. Then the practice on its own. The practice also, you look at it. The also nurses and co-workers that we've all known about. Then we now talk about ideas of quality nursing care. What is the better of us? To be ideal. We talk about patient-centered care, even though from the definition of the recent redefinition of nursing now, we can see that it's talking about people-centered now. In the past, we have been talking about patient-centered. Now it's not talking about people. And that's one of the things we deduce from the new definition. So, patient-centered care, what is expected, what is the idea when you are taking care of your patient? What are the things we know that we are patient-centered. Like we are saying, you are nurses, you are a doctor, whatever, physiotherapist. What is binding us together is the patient at the center that we are all caring for. So patient-centered care. Then effective communication, we also guarantee quality, the effective communication and shared decision making. We also guarantee quality care. If you know how to clearly to give informations that are clear and concise. Also, the respectful communication between the nurses, the patients, and the healthcare. When you do it the way it should be, you see the patient talking to you, they are your friends, and then you know what they need at a particular time. Then evidence-based practices. Gone are the days we just do some things, you don't know why you are doing it. So quantify your care that you are giving to the patient. It must be evidence-based. Anything we do now has to be evidence-based. What are the things you can show? What are the things that we can see clinically? Your clinical decisions. Why are you giving that care? Why are you doing what you are doing? Can people see it? Can the patient and the relative even see what you are doing? So all these ones, we also ensure quality care when we talk about the IDs. These are IDs. Also, the cultural competence. Even in the definition, the new definition, they still mention it. That is now culturally oriented. They want to see it, not just talking about the nurse and the patient. What are other things? Considering the culture, the other people that are involved in the care of this patient. Also safety and accountability. We know as nurses, anything we are doing, like we have the patient, for example, a patient, there are some errors. Medication errors, patient falling down, all these ones, we want to maintain safety and also being accountable for whatever you do. And also continuous improvement. All these ones are ideal. You can't just be on the spot. As a nurse for over 20 years, you've not attended any conference, and you are saying you are giving care, rendering care. Conference, I don't have money. To come for the program, no, I'm too busy. So it needs continual. We know that as nurses, before we can do the ID, but for today now, we've had a lot. And talking about innovations, the kids, the speaker have already told us, and we've seen some diagrams. We've seen how things should be in the hospital. When she was presenting the other time, talking about infusion pump, I was saying, mommy that was sitting by my side, I said, we have that one. So we learn new things. When you develop yourself, continuous improvement, you will improve yourself. Some people, when they get RM, they say, 80 mocha, 82, I've done enough, my children will be reading the rest. You have to know it now. Your children cannot read the rest for you. Or else you will be at the back. You just be complaining. And this one met me here. When did he resume? When did he come to this hospital? So to give quality care, you need to improve on yourselves. Thank God for Unimed now, that we now have masters in nursing, PhD in nursing, and other field. Let's put our hands together. I want to do this. Yes. In the past, before you even get masters, you will see when your eyes will see shaggy. Before they even give you admission in UI. And when you resume in UI, you know where you start. You don't know where you will finish. But now we have the institutions around us. It's not left for us to improve ourselves so that we can give quality care. And thank God, some people that thought they are done reading. Now we have BSc, we have masters, we have PhD. I even have, like the program I'm doing now, even somebody one of the DNS that retired in Osun, still forging ahead to study. So you develop yourself. Not only that, let me just have the BSc and I japa. Because when you japa, you will see it over there. We need to develop yourself so that you can give quality care. All these things are standards that we talk about before you can render quality care. Now, when we now let's look at case study now, because we are talking about patients. You have to be clinically based. In ID, we want to look at ID and reality. In an ideal situation, maybe we take a patient that is in pain. Is medication the first thing? There are some things you can still do. Reassurance, diversional therapy, and then counseling the patient, doing some things, education. Oh, this pain is coming down gradually. The doctor has prescribed some things for you, psychological support, all those ones, before we now talk about analgesic. That is the idea. Not just, she's feeling pain. Oh, yeah, bring, let me come and give her for twin. Doctor, come and write drugs. In this situation, there are some things you have done before you call the attention. For example, if somebody is feeling hot or paresthesia of above 40 degrees centigrade, is it medication that will come first? Is it IV, paracetamol, or whatever that will come first? There are some things you can do. In this situation, you want to open the windows, you want to tap a sponge, you want to fan if there's no electricity supply, you can fan the patient, and if you can on the AC and many other things. Before you can remove the clothes, reduce the clothing. Before you talk about, okay, you now look at it. After 5 or 2 minutes, the temperature is still high. You recheck. Then what we now do? You want to give an analgesic. That is in an ideal situation. And when you do that, like the case study, the patient was so appreciative. He thanked the nurse because he know the nurse has done the best. The pains was well managed and he feel comfortable. And because he was supported, he was not alone. So this is the idea. Now let's look at. So that's the idea. Now, but in reality, is that so? Is that so in reality? So when you look at another case study, you will look at the patient that is also feeling pain, and the next thing is because if he's the only person, he's the only one on duty, to cater for 25 patients. All the idea I was talking about, will the nurse be able to do that? No, she can't do it. But she knows she's in pain. Let me give the medication. So that is the idea. But reality on our hands will not allow us to even to see those ones. Looking at I want to look at that's in real life. Please, sorry, I want to look at the reality now. I was expecting it to be here. Don't know what has happened. The slide is not complete. Before we get to strategies, there are other things that we need to. This one is ID. Reality, this one is reality. This one is reality of nursing care. There's also another case study. This real life. Sorry. I will get the other ones. Let me go with this one. Sorry. I want to just get it. Is it there? The reality. Real life situation. So that is what we are talking about, the real life situation. So what are the strategies? So when we talk about the quality patient care, like I've said, there are some things we need to do so that we know that the patient, we are doing the needful. For example, patient-centered care, in the area, there are a lot to do, even in the area of communication, in the area of discharging your duties. These are reality. These are ID. But in reality, we have some things that are hindering us. Many things that are hindering us. And that's what we want to look at. What are the strategies to bridge the gap between ID and real life nursing care? Either we like it or not, people will still be going. They'll still be living. Some people are even, the japa now is not even only to abroad. Some japa within. And even abroad, people see japa to another place. From London now, they japa to Australia, to Canada. But, so that's telling us there will still be shortage of staff. So how can we do all this work to bridge this gap, like we see in the case study, is to bridge the gap between idea and reality nursing care situation. We should consider the following. Standardized pain assessment tools, we have talked about that one. The keynote speaker has talked about that one. Then provide emotional support. That one is also very necessary. To bridge the gap, so that you won't just say we are so busy, I'm the only one. We still have some things we can still do that cut across, not only the nurse. So implementing tools like the numeric rating, scale of wrong barriers, and whatever. I decided to leave some, even though I will resend the slide so that we can have the comprehensive presentation. There are some things that, when you talk about the reality, what are the things that are not making it to be real? For example, we have the burnt out. When you are the only one doing the job. Some people now, in the past, by the time you attain the grade level of matron, you will not be the one doing dressing again. You will just be rolling on the chair, calling people to come and do this, calling them right and left. But today, we even have directors, level 16, still doing dressing. And maybe that was why in the past, I don't know. By the time you become, they are calling you matron, your buttock will be like this. Because you are just rocking the chair. So, workload, emotional chores. Those are the effects where you see that we don't make it to practice the idea. A lot of times you are worn out. At times emotionally, when you are doing it, you are not commended. Because they are believing you are not doing the best. What of the area of documentation? You can't document it. Many people will do your work, but to have time to even document. So all these ones are what we talk about, the reality on our hands that I cannot find here now. So emotional chores. What of leader mentoring? Many a times now, in the past, when you finish the work in the morning, you gather the nurses, your followers, you begin to lecture them as the head of unit, the ward leader. We want to talk about, okay, let's take one patient. Let's discuss this patient. Those are ideas. Let's talk about this patient, what and what. Oh yeah, let's look at what we can do again for her to make her better. We want to again let's look at the care we are giving. We're supposed to have been discharged. Why is he having these wounds ought to have healed by first intention? What is happening? But today, how many leaders in the house have time to do that? Calling your followers, oh yeah, come and tell me about this patient. Let's see what we can do. How can we help them? Even the area of advocacy, we cannot do those ones. It takes only God. Or you use your extra hours to do that. Mentoring is lacking. And that's why if you are not careful, this new generation, because either we like it or not all of us seated here, we travel out. And what becomes of you in your old age? If you now come to the hospital, they have baby people that are there, you don't have time to treat, to mentor them in the area of standardized or ID nursing. Now, when you now come back in old age, and there's one on duty, what will happen? So, that is why in the area of mentoring, we still have to continue. So, what can we do again to bridge the gap? Providing emotional support. Some people are passing through a lot. It doesn't have to be patient alone, also us. Then, leveraging technology. The keynote speaker have talked about that one. Then, collaboration. To make it better, we can collaborate. She has said a lot. We are not in any competition. So, it is a teamwork. We collaborate. Doctors will come. But like the keynote speaker said, he said, even we accept. We are always afraid of change. Some of us will believe. Now, some people, some nurses, you ask them the idea. Patients need some things and you can give. You say, let the doctor come. Let the doctor come and write it for her. And the doctor have not written it. So, please, attendant, go and call the doctor. And you can set the line. You can repair episiotomy if you are a midwife. The site, you can repair it. Episiotomy site. But because you believe, the one I'm even doing is too much. So standardized care, quality care, we can also give. And also, enhancing nurse education, I've talked about that one, training. Not only when you go, some people when you, some of our nurses, we want to give quality care. And then, when you talk about money, we are nurses here. They said, okay, there is a program going on in South Africa. Come and register. How many of us will go and register? And you know it will touch you, your care, that maybe the team is even dealing with what you are doing in your ward. Or even as an academician. Many people say, if they don't sponsor me, I won't go. Who will sponsor me? So we need to improve, and by the time you are coming back, you can use whatever knowledge you have gotten. So leadership support also, leaders to bridge this gap. Let's support the coming followers, our juniors. Let's support them. If they want to go for example now, many of my nurses are in Unimed, they are in Bangkok studying. Because I'm the one that I said, many of them, go and study. Some people think, there was one that was very close to me. She got her BNSC at the age of 60. And when she came and told me, I'm done, I have to work. I say, can you see now your children cannot read it for you? Congratulations. So we should advise, as leaders, let's support them and then advocate so that they can give quality care when they come back. It's not every time you say, no time. Who will do? I remember then, if you are going for study, you will do a lot of work. There are some people then, they will relocate, they will go and have transfer in HMB to transfer them to the remote areas. But there was no phone then. Before you know it, your guard, the apex nurse then, will come to HMB to tell them, the person you transfer to me, I've not seen her. Because how will such people grow? So in the area of leadership support, okay, very, very important. Implementing quality improvement. One thing I tell people is, once your duty is not lagging, once your word is covered, once you have programmed yourself, even though again, some people will abuse it. Even when they are not writing exam, they will tell you they are in school. because we believe that is what we should do, helping them so that they can give quality care. In the past, when you have malaria, what do we use? Chloroquine. Do we still use chloroquine to treat malaria now? Even what we call it, typhoid. We know white capsule, like the lame people will say, chloramphenicol. How many things are changing? So that is why we too must move with time so that we can give quality care. Technology, promoting staff welfare and retention. Today, some people are moving around. They go to other places, even within Nigeria. Why? Because they are better paid. And one thing we should know, the nurses of nowadays, this younger generation, with difference of 40,000, they can resign. Somebody is paying 120, and another state is paying 100,000. Some people will resign. They will not consider, if I resign and go to another state, my family is in Ondo or is in Ekiti, and I go to Ogun State, I will be managing, shorting between two houses. They will leave, either we like it or not. So we have to have the retainership package, and it is until then that we can see what we see that our people. In conclusion, the idea and reality of nursing care are intertwined. They are interwoven. They go hand in hand. With the ideal of patient-centeredness that is evidence-based, the care you give, that is being influenced by complex factors, the acknowledging the challenges and opportunity in nursing care, nurses can strive to provide high-quality care. You can strive. It may not be easy, but you can strive. We see how people, some patients that still commend nurses. We see people when they are discharged, they still send gifts. Some we even call. If not for the not so, I would have been gone by now. Some will see, when they see you in the market, I remember then, when you go to the market, what people are so wonderful. I work in Ose local government, in Moru precisely then. If you go to the market and you carry your basket, before you look back, you will see them dropping something in your basket. In the time of corn, maize like this, you will carry load. You will see fish, frozen ones, the one that the smoked fish. You see them dropping it. It comes to a point, I won't even go to the market. I'll be sending the attendant. Because they appreciate what we are doing then in the basic care center. So let the patients commend you. And don't wait till they give you they appraise you. Let God take care of you. When you give quality care, anywhere you get to, or your parent or your family goes to, you get it. And that is it. So let's serve this one, and so that we can let's strive. Let's strive. Some people will say we are very busy. We are busy. And yet the patient is there shouting. We are pressing phone. I heard recently, somebody said, this MCPDP, a patient was crying, shouting in the ward. Another nurse came from another ward to come and be discussing with the nurse on duty. I said, what happened to this? Your patient is shouting. Leave her, let her be shouting let her be shouting there. And we are saying we are short-staffed. You are the only one on duty, fine. But strive to give quality care. Let us leave this place today with that notion that we want to do our best. And also, by prioritizing professional development, quality improvement, international, some of us, we can't collaborate. When you see the doctor, you are threatened. When the doctor or even your colleague is saying, why not do it this way? You want to resist it. Is it the one that will teach me? Because he has gone to school now. Which kilo katimioka? No, I won't take that. She can't correct me. Even she's my junior. Anybody can correct us. When we talk about giving quality care, let us make it interdisciplinary collaboration. Nurses can bridge the gap between the idea and reality of nursing care. The idea, we know it. We know the standard. We know the framework. We know what our council is saying. We know what the WHO is saying about nursing. Let us do whatever we can do to strive to give quality care. And I want us to go home with what I've said, the take-home message. Quality nursing care do what? Let's take it together. Quality nursing care improves outcome, reduce suffering, and uphold dignity. And these are the references. Thank you.
Round of applause. Thank you very much for that beautiful presentation, ma. We wouldn't know if there are questions, ma. Ẹ má tí lọ o. Bóyá wọ́n ní question tán fẹ́ bí yín o. We want to entertain questions. If you have questions, you need something you want to clarify, the floor is open for us. It is true we are doing conference, but it's not time to just come and be sitting down, just be watching. No. It's time to throw out your mind here. Oh. You know this one is not classroom. Nobody will punish you for this one. So ask question. Oh. Any question, please? You understand everything? Question? Oh, she mistake, okay. Okay, there's a question here. Okay, there's another hand here. 1, 2. A quick one. Okay. So you please introduce yourself by telling us your name. And then.
Good afternoon, everyone. Thank you for the lecture, ma. Yes, I've been observing nurses, for some times now. And maybe my name is Olafse Mbolaji, a staff of UNIMED, Public Relations Unit, to be precise. So I could remember then when I wanted to add my first issue, the nurses on call then, they pepper me, like, I was just like, being the first timer, I was expecting something, empathy, like mommy said, like to empathize with me and all the rest. It's just like, she said, my Pembi. I was just like, what is really happening? I said, call me my mommy. Because, and even some subsequent ones, or even my sisters, some of them also experience such. So I want to know that, why do we have some nurses that are so saucy, they lack empathy, and they just like, maybe because I was like, maybe because, yes, the way some will even look at you. So that's my question, ma.
Thank you. Let's pick all the questions together. There's someone here too.
Thank you, ma. I want to say, because I don't want us to mix it up. When we talk about nursing, I said the other time, that's why I said the slide is not complete. So that we have what we call, as developed by Roach in 1993. He talked about 5C of nursing care, of a nurse. Talking about compassion, about caring, about composure, and what have you. Many people today, I can say it is multifaceted. This issue we are talking about, because I want to believe it's supposed to be in the past. Nowadays, why are we still having the issue? Some of us want our children, like the guest speaker has said, we want them to be a nurse. We want them to be nurses. I said it will go of the time. The passion is no longer there. So that was the one I gave example. Then when you see a patient shouting, what will you say? And recently, 3 days ago, somebody called me, one of our top manager. He said he has a patient in Akure, and he called me. He said, please, what can I do? The patient will be there in labor, first time, like you have said, first timer. He said he has been shouting since yesterday. And even the theater, they are saying, theater loma pari esikeyin. And I said, that was how he told me, a man. I said that, please, let me say, I will see what we can do to encourage her. Maybe she's just starting. And I just called, and I said, even though they are no longer with us, I said, please, I have a patient, and I mentioned the name. Let me look after her. Let me know. I want update on that patient. And she told me and said, just 2 cm. to me, I'm a midwife. I just called the man back. I said, please, sir, tell the husband and the people that are around her that she should still be patient. Maybe she came at the right time. She came with forced labor. That's what we call forced labor. That maybe that the opening is the service is just opening 2 cm for a prime hip. And I told the lecturer, I said, for a prime hip, you will spend 18 hours before you can be talking about, because that is, I don't know whether it has changed you. That's the way we are taught. Midwives. First time 18 hours. So 2 cm is just, Moani, she's just starting. And could you imagine, I said I'll be monitoring her. And that was what I did. And I said, don't worry, she will deliver safely. And he told the husband, and he was contented, and the patient went through the labor phase. And when he was calling me the second day or the third day, he said, let me first of all thank you for what you did. The same man that called me, that she delivers safely. Compassion. Patient, you don't know who will be the next person. That is why, and that's why you are having problem. All of us want to, and I always ask the students when you bring them, if you have been forced to come to nursing, let me know. When I have meetings with them, because how will you see some people? Because how will you see some people? Patient is in need, their need of a nurse, and you are in the ward. You don't even know what to do. Your mind is not there. You are pressing phone, and when you jackpot, do you press phone over there? The passion is no longer there. If you have passion, then you go extra mile. I know some patients, you want to close in labor room. They will say, Auntie, no, say, my see law, you will wait till 6 p.m. and they won't give you anything. You are not paid for all those things. So we have been talking about it, and it will change. We continue to talk about it. And you parents too, I know as you are seated down, you want one of your children to be a nurse. Can you see? Either she's interested or not.
Thank you very much. The last question, a quick one.
Good afternoon, ma. My name is Teni Olami. You spoke about nursing, the definition of nursing previously, that it was patient-centered, but now it is people-centered. I didn't get that part. Like, what's the difference between patient?
She wants expansion on nursing as a people-centered care.
When he was talking about that, she was just defining nursing, a care you give to a patient that he will have done if he has the will or the ability to do so, or even to nursing to peaceful death. So you want her to, or the patient to be independent, so that what he has been doing before he can do it. Now, they said it has to be people-centered. It's not only that patient. People-centered care now is what we are envisaging. Patient is part of it, but not the patient alone. The patient may have a wife. Like the patient that called me now. It was the husband that called me, not the wife, not the person in labor, not the patient. So what are the people that surround? No, it means when you are caring for the patient, you also consider caring for, because psychologically, somebody that is on the bed in the ward resting, that is sitting, and you come and take your drug, is relaxed. What happened to those that are running about for money? Those that have another baby at home, the husband is at home, and he has to come and give food to the wife in the hospital. What happened to other children? What happened to his own work? Will he not go to work? So, but when you manage them together, you get the good care you need to give. He will be able to listen to you. He will listen to you. He will take all your advice. That is what we are talking about. It's not only the patient. People-centered.
A round of applause for that. We have a contribution from Prof. And they will be moving to our abstract presentation.
In addition to that, the people-centered concept is beyond patients. We are also looking at prevention. The person who is not sick is not a patient, but the focus of nursing is also on that person, so that they will not be sick. So the new definition of nursing is looking at care even at the prevention stage. Thank you.
Thank you very much, ma. So, nursing definition now is beyond just clinical, but community, from the side of community, population-centered care.
Get it. What have you disconnected it? There's some for you. So I've just seen it now. The definition, the new definition. Oh, and B. That's why I said it's not complete. So that they can see.
ICT, we need to project this.
Let's see it as we are.
We need to project this current slide.
Looking at it.
This current slide, we need to project it.
That is the definition of nursing by the International Council of Nurses Board and by the clinical nurse researchers that was approved precisely June 9, 2025. So that we can study it and we see. Sorry, just a minute so that we can see it. It is here. I put it there. So when you are doing other things, come confidence only come out. Ìdajì. Some of it are not there. There's supposed to be 22 lives. I will attach to you.
Okay. Let's give her another round of applause. We thank you for your presentation, ma. So a take home this time around says that nursing is no longer patient-centered, but people-centered. Looking at the care of a population, not just an individual. So we have a lot of take-homes today. And we'll be moving quickly to our abstract presentation. So we want to look at the current nursing definition. Then we'll be calling on our speakers. All abstract presenters, you have just 10 minutes for your presentation, please. So you need to be fast about your presentation. Okay, here is our new nursing definition according to ICN 2025. Can we read that in unison? 1, 2, go. To enjoy the highest attainable standard of health through a shared commitment to providing collaborative, culturally safe, people-centered care and services. Thank you very much. Thank you. So you might need to go online and get this current definition. Perhaps it's going to come out in your exam. Thank you.
Thank you very much. I'm happy to be in your midst. I'm very sure you are happy to have me too. Wow, that's very good of you. Permit me to continue on the assisting protocol because of our time. We'll be looking briefly on intermittent fasting in prevention of chronic illness and psychiatric disorder. We looked at narrative review anyway. So we look at narrative review so that we can support our claim and concept of intermittent fasting.